Did the academic foundation program at George's for 2 years on the vascular surgery theme. And then I am now a core surgical trainee in Essex, and I want to do plastics. So I'm quite keen on research, quite keen on academia. And for a while, I always wanted to do the AFP. So it just seemed like a no-brainer. I applied to London and West Midlands at the time. And now it's, I don't think much has changed in the application process. This was probably like 3 years ago or so. So if we go to the next slide, please. So yeah, just briefly about some of the things we'll be going through. The presentation is predominantly focused on interviews and to getting through the interview stage. As far as I understand, the application window for the AFP opens soon and closes early November, I think on the 4th of November. So I think at this stage, you probably will have your portfolios and will have all the points you're going to score for anyway. So I didn't think it was much use about talking. There was much point in talking about how to enhance your shortlist score because it's all pretty much decided now. But yeah, we'll just go through kind of a bit of an introduction and give some example questions, which me and some of my colleagues have faced in London, West Midlands, Cambridge, Oxford. So quite a broad range of deaneries. Can we go on to the next slide, please? Perfect. Yeah, so the main thing is just going through the different types of questions. We will cover some different questions. It's mainly about the approach. So it's mainly like 1 or 2 questions each for clinical and academic, but it's predominantly the approach. And then we'll go over kind of useful hints and tips to bear in mind. And then, yeah, feel free to ask questions throughout. We can talk more generically about the application prior to interview once this is all over. We go on to the next one. Perfect. So this was normally given at a stage where people had interviews. But first of all, I mean, congrats on thinking about applying for an AFP. It's competitive. Even if you don't want to do research, there's so many streams of different academic posts, so leadership, management, teaching, and it's all useful, even just to get a taste of this or to put it on your CV at the very minimum, because it does look good. And for the rest of your medical career, you will be interviewed. Your applications will be competitive. It's only when you leave medical school, that's when everyone is pretty much guaranteed a job of some sort. But after that, to get the job of your choice, everything becomes pretty competitive. And for most of you, you wouldn't have been interviewed before medical school, which is going back maybe 5 or 6 or maybe like 7 years. So it's a long time. So it's good to get into the habit. So if you're still on the fence about whether you should apply or not, I definitely recommend applying, because number one, you lose nothing apart from a bit of time filling out the application. And sort of the second point is, even if you don't want to do it, it just looks good on your CV. And it also gives you another option to say, for example, if you want to stay in London or if you want to go to a deanery, which is fairly competitive to get into, relying on your SAT alone, which will account for 50% of your marks. And essentially, it's partly luck as well. And that could go wrong on the day. But if you have an AFP, that provides you like a second option to get into the deanery, the location, and the job that you want to do as well. So overall, the benefits far outweigh the risk of an application. The types of interview that happen, so in London and West Midlands and sort of all of the deaneries that I'm aware of, there tends to be a clinical component. And at the end of the day, they all know you'll pass finals, because everyone will be like on the GMC provisional register by the time it comes to work. So I don't think they're too concerned about your clinical acumen, but they want to know how you think. And essentially, you'll be doing the same clinical program as your normal foundation program peers, and having to complete the same number of assessments and meet the same requirements, but just in a shorter period of time, because you'll be taking a total of about 4 months out just to do research and have no proper patient contact. So they just want to see if you're organized, if you're ahead of the game, and if you know how to think, essentially. There's always an academic component, obviously, as is in the job title. And then sometimes there's a bit of an ethics and law section. I gave this lecture at Cambridge, so ignore the CEO handbook. That's just a lecture series that they have there. And then a bit about generic interview skills and like the leadership and management things and clinical governance, knowing what an audit is, all of those kind of basic things. Can we go on to the next slide, please? Yeah, perfect. So clinical scenarios. The majority of clinical scenarios won't be difficult. And essentially what will happen is they'll give you more than one clinical scenario. So what I've done here is present a very similar question to what I was asked. So these were my 4 scenarios when I went to my London interview. And essentially, I used basically a very simple way to approach it. So rate, so R for recognize, A for assess, T for treat, and E for escalate. So first of all, going off of the clinical scenario, I walked into the interview room. So you'll have 30 minutes or so just to read an abstract beforehand and make notes, but you can't take that into the interview room. You'll subsequently have your academic and your clinical interview, and there'll be 15 minutes each. So on the clinical part of things, I was just told about a few patients. So first of all, there was a patient who just had a lap chole, and the nurse had called me because the patient was scoring a 7 on the EWS system. So typically nurses have their own way of escalating things. And by now you've been on the wards long enough to know that if the patient is scoring high enough of the OBS, then the nurses are kind of routinely required to escalate via the appropriate streams. So that's the very first call I've got. On my way to review this actual patient, an angry relative stops me, and basically they're a bit annoyed because their mother, who's a patient, hasn't received pain relief that she's been waiting for. However, on the actual ward, when I turn up, I witness a patient fall out of their chair whilst trying to mobilize. And meanwhile, there's another patient trying to self-discharge because they've been waiting a long time for the angiogram. The nurse has kept bleeping me about this self-discharge. So essentially, you've got 4 very busy things going on here. And the chances are most of it won't happen all at once. And as you can see, it's not really about your clinical knowledge per se. So the first thing they want to know is whether you can prioritize. So a lot of the job you'll have will just be about kind of prioritizing as an F1, because you'll be getting called all over the place, and it's about doing things in a manner in which you address what's clinically urgent first, and then again go on down the list. So that's all I was given, and then I was asked a very broad question of how would you proceed. For the rest of the 15 minutes, I was pretty much left to speak, and at points they'd ask me the odd question, but it was very much led by myself. If I was talking about something, they'd just ask, like, what are your differentials, for example, or what things are you considering? But it was very much led by myself. So it's 15 minutes of just talking through what you're going to do. Other interviews may not have this approach. But again, the more you can kind of take an examiner or an interviewer through your thought process, and the less you require them to kind of pipe up or ask you questions, the greater control you have over how well you do. So I've used the R here first because you need to recognize that there's lots going on, and the first thing you need to do is prioritize. Bear with me, I need to plug my laptop in. Do we still have people in the audience, Sophia?
Yeah.
Perfect. Okay, and let me have a look. So we still got the 2 people. Perfect. Do you guys? So who have we got? Gemma and Leah. Do you guys want to unmute yourself? Are they able to contribute?
I can stop the recording if you...
Oh, fine. No. If not, don't bother. I thought it was interactive. I'll talk through it. I thought it was more of an interactive thing. Give me a second.
Sure.
Give me a second. Cool. All right. So how would I approach it? So first of all, you have to appreciate that this is a difficult scenario, and so you have to make a strong point that you're going to prioritize and approach it in a clinically kind of appropriate way. So you need to identify who's sick and who needs to be seen quickly and who needs to be seen because they're not sick. So going for it, the very first case, the patient's just had lap clearly and they're scoring high with their OBS. That patient is clearly sick just looking at the numbers. Second one, patient's in pain. So again, part of the Hippocratic Oath is also doing right by the patient as well. So treating the pain is very important just from a symptomatic point of view, and it has a massive impact on the patient's experience as well. So again, that is relatively clinically urgent, but you've also got a sick patient in point one. Point three, someone's just fallen out of their chair. Again, you don't really know what's happened, and a four could be anything. They may have had a seizure, they may have arrested. So many things may be going on again. So there's a lot of uncertainty here. And four, again, if the patient is well enough to say that they're self-discharging, then clinically, it doesn't sound as if they need your attention right now. However, they are awaiting an angiogram of some sort. If this is a coronary angiogram and there's someone who's probably come in potentially with an NSTEMI, then again, it would be relatively unwise to let them go home and pretty unsafe without properly counselling them. So the first thing to do is to know that there's no right answer. So you need to take your examiner through each of the points and say why each point is important. Because standing alone, it's very difficult to say who's more deserving of you, but you need to go through and say which one is clinically urgent and which one is just urgent. And then from that point, you can rank it as you please, and there's no right answer. So say, for example, you've got the first case that needs to be seen. You've also got someone who's fallen right in front of you as well. So thinking about it logistically, someone who's fallen right in front of you, you're already there. And so there's things that you can be doing. Someone who's going an EWS of 7 over the phone, there's stuff that can be done on your way to see the patient. And also it's about recognizing that you're not in a team you're in a team and you're not on your own. So how I answered this was I addressed the patient who'd fallen, and then the patient with the EWS of 7, then the patient who was in pain, and the one who's threatening to self-discharge. But again, people have gone for completely different approaches and it's all worked fine. The second point is about assessing it, the patient, so A for assess. And it's an A to E assessment that you hear over and over and over again at medical school, and once you start working as well. Again, you have to be flexible and prepared to discuss any... do you mind changing the slides, please? Thank you. You have to be flexible and prepared to discuss any differential diagnoses or management plans instead. Because as I said, they let me speak very freely, and in most cases, they'll probably let you do so. However, if once you have a good A to E, they'll start to ask more specific questions like, what are you thinking? What specifically is going through your mind? What would you like to rule out? So out of all of these, I only went through a proper A to E for one patient. So say, for example, I've chosen the patient who's just fallen down, and I've gone to see that patient. I'll go through a thorough A to E with that patient. And given it's a 4 and I don't have much detail about it, I'll treat it like the proper ATLS trauma protocol. So starting it off with like the C-spine, airway, breathing, circulation, disability, and exposing the patient. And by now, you should have very thorough A to E's. Additional hints and tips that you can potentially add in is just to show you're a well-rounded doctor, is maybe putting in an F there. So, for example, making sure that once the patient is stable, that you're updating, for example, their family or their next of kin who's potentially worried. And it shows that you're thinking a bit more outside of the clinical picture. and you're just a well-rounded doctor. So once I've gone through a good A to E, when I then go on to see the second patient who's scored an EWS of 7, all I need to then say is I will thoroughly assess the patient with, for example, ATLS or QUEST algorithm using an A to E approach, as I've previously done. And again, they'll hurry you through it. They won't expect you to explain it twice or once they've seen that you have a good, appropriate method of assessing the patient, that will be fine. So you can talk more about specifics and say, for example, in that situation, they might be asking you, what are you more concerned about? What are you worried about? However, examiners, I call them examiners because it is basically an exam, but interviewers are very tired of hearing A to E day in, day out, especially when they're interviewing. So it's definitely the right thing to do and the right approach to take, but just don't be thrown off the ball if they then kind of try and seek some more specific answers from you. So my friend who was interviewed at Cambridge, he wanted to do ortho, and so it was a very ortho-specific question. Patient had come in who'd had a femoral fracture, had an RF, and essentially this patient's complaining of pain. So he started to take them through an A to E, and they were like, yeah, we understand, you know your A to E. As soon as he mentioned B, so he didn't get very far down. They asked him, what are you most concerned about? And at this point, it could be a broad range of differential diagnoses, but because you've been completely thrown about not going through your normal algorithm, you begin to freeze. So the main thing here they're trying to rule out is stuff like compartment syndrome. So don't forget the obvious differentials and the most dangerous differentials. And also be thinking on your toes that although you take them through an AT, be very flexible and open to changing. Can we answer the next slide, please? Thank you. So T is for treat. So again, they all know you're going to pass finals. However, you do need to have some clinical knowledge, and it ties in at a good time where you can revise the finals. All I used was the Oxford Handbook of Clinical Medicine, and the clinical emergency section at the back of the book was very useful. Essentially covers most of the things you need to do. So say, for example, a patient with exacerbation of COPD, or, for example, patient with, acute severe asthma, a broad range of medical emergencies that as an F1, you're expected to be able to at least initiate the management for. So that was about the breadth of the clinical knowledge that you needed to know. Obviously, if you're applying for an AFP with a particular theme outside of London, so the problem with London is that you rank all your jobs, and so everybody has a very generic interview, and no one knows what your first choice is, and so they can't theme it. For example, if you want to do hematology, they're not going to give you hematology theme questions. But outside of London, where it's a bit more themed, obviously having an interest in what you've applied for helps as well, because again, they could ask some more specific and niche questions. The second part of treating is, although you're very aware of, for example, what you do with a patient who had an exacerbation of COPD or any other medical emergency, it's about knowing your competence. So knowing that theoretically you could, for example, start someone on aminophylline or give them magnesium. Everyone would know that theoretically it's possible and how it works. But again, as an F1, you're very unlikely to jump straight to that if you've tried and exhausted all other methods or forms of management without escalating to one of your immediate seniors or the medical registrar or the ITU registrar. So it's about acknowledging that you also have a team around you. And it's not just the MDT in the sense of other types of specialties and clinicians that you can refer to, but also knowing that you have nursing staff, HCAs, PTs, OTs, pharmacists, dietitians, all of the allied healthcare professionals. Just have a broad understanding about what they do and when you can call on them. So in the very first scenario, when a nurse has called me about a patient scoring an EWS of 7, there's certain things that I could ask the nurse to do. So knowing that HCAs are able to take observations, I'd ask for a full set of the HCA over the phone to take a full set of observations. Knowing that nursing staff are well equipped, or most of them, in taking a basic set of bloods and put in a cannula in, you could ask the nurse to do that. And there's certain things you could do to initiate management over the phone by just verbally handing over to your allied healthcare professionals without necessarily being there. And so that's one way of prioritizing things. So if you're dealing with a clinical emergency in front of you, there's certain jobs that you can get the nurses or other healthcare professionals to do before you then arrive. And again, it just maximizes your efficiency for when you do turn up. Can we go to the next slide, please? Thanks. So the next one is E, so escalate. So it's R for recognize, A for assess, T for treat, E for escalate. Escalating early is very important. However, you don't want to escalate before you've even seen the patient or you formed any kind of initial treatment plan. So you all know about handing over with an S-bar. And a big part of the S-bar is the assessment and the recommendations, the A and the R. However, if I was to get a call from one of my F1s to say a patient's just spiked a temperature or a patient is unwell, and they were essentially just relaying on a nursing message, it would be very frustrating knowing that the junior doctor himself hasn't gone down to fully assess the patient. No one's saying spend ages and ages with the patient, but everyone's kind of, as a medically trained professional, you should be able to at least see the patient. If it's not too much of an emergency, initiate some form of medical management before then escalating. However, if you're completely out of your depth, then escalating is definitely always the right answer. So in all of these cases, I'd always escalate it, knowing that you're still on the provisional register and you're still only a junior, an F1, sorry. Most of these scenarios should be then reviewed by someone who's definitely more senior than you. So it's about timing the escalation. So I've done my A to E. And for example, if a patient is hypertensive, I've taken a full set of bloods, observations are all fine. And I've started, for example, some initial management. So if it's a septic patient, I've started at least some of the sepsis 6 and then contacted my registrar for more appropriate help. So it's about knowing who to call. First of all, always escalating within your team before then escalating outside of your team. So knowing basically what are surgeons interested in, what are medics interested in, what is ITU interested in, what is, I don't know, the hematologist or dermatologist interested in. So it's about knowing who to refer to and when to refer to them. And again, these patients, for example, can't, because they're sick, there may be a peri-arrest call, or they might just be in arrest call. So knowing about how to activate these at your hospitals. And again, an outreach team may be at your hospital. So all of these are unknowns because they've just given you a hypothetical or model hospital and told you that this is your scenario, go on and get on with it. But it's worth mentioning each of these things when you are talking about escalating, because it will vary upon the actual hospital you go to. I'd avoid going down to specific antibiotics, for example, specific forms of treatment for some things which will vary according to trust protocol. And it's just about showing awareness and knowledge that you do know that things differ between trusts. Can you move to the next slide, please? Thank you. So the second part is just the academic part. As I said, for the London interview, you had 30 minutes to read an abstract and then make notes in the abstract, and then you couldn't take any notes into the interview itself. Can we go on to the next slide, please? So with London, there's less of an emphasis on a kind of personable interview. It's more very generic. However, they still do ask you some basic questions depending on if they have time. And it says if you're applying to outside of London, it's a lot more about what you've done rather than about how can you interpret this random paper. So the first point is your CV. So knowing your CV very well, knowing anything you've kind of ever won, any prizes, any publications, any presentations, any audits, but also being able to explain your role in each of the projects. So a lot of the time, say for example, if you've been like the 5th or like the 6th author out of like 10 authors on a paper, it's about acknowledging that on that paper, you contributed X, Y, Z to that paper. And again, it's about knowing that, again, although you might not have written the paper, although it wasn't your idea, you didn't do the analysis, you at least helped with data collection, for example. So a lot of the time they'll ask you specifically, what did you do for the paper? What was your role in it? And it's just about being aware, because you've done it at this stage. So just flick through your publications and presentations and remind yourself before you go. Be able to kind of critically appraise your own projects, especially if you've led it from the start. You know your projects very well, and so you'll know all of the flaws in it. So be able to kind of say some drawbacks, and mention some drawbacks and limitations, and how you will improve it if you were to do it again, or if you were to do further work, without completely ripping your projects to parts. And then try and connect your projects to what you've done in the past and what your research interests are. So say, for example, if you want to do ortho, and you've done a couple of ortho projects which you presented and maybe published a couple of them, it's about then linking it to, say, in the future, like, I have an interest in, I don't know, minimally invasive hip surgery. And again, that's something I'm potentially interested in exploring during my AFP or further on down my clinical academic career. So it's about the past, the present, and the future, and always trying to link the three and to show some kind of continuity in what you've started, even if you're just making it up. The Whitespace questions are all outside London. London don't use it anymore. But again, you have to know your questions. So typically they'll give you 6 Whitespace questions, which don't really change year to year. And it's just like a personal statement. It's about being active. They'll ask you typically, I don't know, essentially, why do you want to do this program? Why does it benefit you? Tell me about a time where you demonstrated good leadership or management skills, or what's your experience of teaching like? And it's always like a personal statement, being active, about saying what you've gained from a process and reflecting from it. 1 second. So I was just getting a call. Sorry. Perfect. And then going on to your Whitespace questions. So once you've done them, make sure you get a good few people to read them, including people who have done academic jobs in the past, just because they'll kind of know what people are looking for. And on the interview day, know exactly what you've put down, so you can't be called out. A lot of the time, outside of London, they'll ask you just to expand on your Whitespace questions, which is a fairly easy and quite generous question. And then, again, like the past, present, and future, knowing what you've already done and trying to link it to what you're planning to do and your future potential research interests. It's all about knowing the basics of research. So if I had a research question, and I think this comes up on some Whitespace questions, if you had like £1 million or £1 billion, what research question would you want to answer, and how would you go about doing this? So it's about knowing how to conduct research, from the very construction of the idea to the kind of research and ethics, the IRB approval, the grant proposal, the grant applications, to the patient and public involvement, to then actually trying to carry out the research and recruiting patients, recruiting centres, to the data analysis, to writing up, to disseminating the papers. So knowing the whole research cycle. And at any point in that cycle, they could ask questions. Say, for example, so where do you think you'd get this £1 billion from? So where would you get funding for this? And that's something that I was asked at London. And essentially, they just want to know that you're aware of different research institutions or charities which fund different academic projects. And again, because you are applying for the AFP, you have to be aware of what the integrated career clinical academic career pathway is. So I'll put that on the next slide. So, here it is. So you're at medical school. Some of you may have intercalated. Some of you may have done PhDs whilst at medical school. Some of you may have done all of this before medical school. The academic foundation program comes in afterwards. So you have 4 months during F2, either as day release or like a 4 month standalone, where you get to do research or involving yourself in teaching, leadership or management. And then following on from that, you can apply for an academic clinical fellowship, which is 3 years. That's a 25% time, 25% of your time is dedicated to research. And the whole point of that is to try and gather preliminary data to for a thesis proposal for potential higher degree, like an MD or PhD, at which point you'll take a few years out, pursue the PhD if you get the grant, and again, go back into training. After that, there's usually like a clinical lecturer post, which can be 50-50. And these are all integrated, 50% clinical, 50% academic. And eventually you can go on to, once you've completed training, to be like a clinical scientist, professors, all of that. So it's just about being aware that you're at the very start of this academic ladder. And a lot of the time, although it's good to want to do it to get a taste of it, even if you don't plan on pursuing research further in your training, it's good to kind of give the impression that you are considering it and you're very aware of what pathway you're taking. So say, for example, you'd want to do an AFP because it provides you in a good stead or good understanding of basic principles of research, and then go and apply for an ACF, and you do have an interest in pursuing a high research degree like a PhD in an area of interest of yours, like, and then again, you can just mention your area of interest. They can ask very specific questions like they did at London and just say, how much time do you get off for research during an ACF, for example? So again, knowing the whole path just helps answer all of those questions. Can we go on to the next slide, please? And then what formed up, so it was 15 minutes. Half of the interview was about critically appraising the abstract you read, and half was just random questions in London. Outside of London, there were, again, a combination of the two, but all basic principles about how to interpret data and how to read a paper. There's a book called How to Read a Paper, which you can have a flick through. I think it's relatively useful. It's probably a bit too long, but worth having a good flick through before you do go to your interview. And how to approach anything is the PICO approach, which you probably heard of before. So population, patient, problem, I for intervention, or what the exposure is. C for comparison. So what cohort are you comparing them to? Or is it like a control drug, for example? And O is the outcome. So the very first point of actually summarizing a research paper, they will just ask you to summarize what you've read. And a very good way to summarize it without repeating the title is just to PICO it. To say, for example, this is a study, like, say the type of study is an RCT looking at elderly patients over the age of 60 years old who have fallen and had a hip fracture, comparing the use of, I don't know, a novel dynamic hip screw compared to the old-fashioned or the current traditional dynamic hip screw, looking at what their 30-day morbidity and mortality is, for example. So it's just a very easy way in your head to summarize it by just going through a PICO. Like anything, you have to know all the study designs. So RCT, case control, what else do you have? The case series, even just like the hierarchy of research evidence, from kind of opinions and letters to case reports to case series, RCTs, case controls, non-randomized studies, prospective longitudinal studies, cross-sectional studies, all of the different types. Just know the kind of advantages and disadvantages of each. And obviously the gold standard right at the top of the evidence pyramid would be like a meta-analysis of top quality RCTs. Below that would be like a top quality RCT. So before you go in, it just provides you easy points to critically appraise a paper, because if they put an RCT in front of you, or you can, and if they ask for the drawbacks of this study, you can just list off the drawbacks of an RCT or the benefits of an RCT, because it won't change. All you need to do is identify the type of study it is, and then just reel off what you know about the advantages and disadvantages of that particular type of study. Statistical definitions are a big one, because, again, with the whole interpreting a paper, it's about how you, for example, if there's a p-value, what's the significance of that, and how does that sway your analysis or your interpretation of the actual paper. But it's also about trying to see where people have tried to make sense of things or force an easy or quick publication by fudging the statistics as well. So there are a few basic stats books out there, and I just advise you to go out and have a read of just very simple things, because there are simple things like what's the mean, what's the median, what do we mean by p-value, what's sensitivity, what's the positive predictive value. All of those basic definitions should be well covered. However, again, another generic point to raise when you're critically appraising it is to also say if something is statistically significant, it doesn't necessarily make it clinically significant. So just because something has confidence intervals which do not cross 1, for example, or a p-value which is less than 0.05, the actual difference might not be clinically significant. So say, for example, I had 2 antihypertensive drugs, drug A and drug B, and drug B lowered my systolic BP by 0.01 millimeters of mercury compared to drug A, then, okay, fair enough, that's statistically significant because the p-value came out to be, say, p equals 0.01. However, it's not clinically significant in terms of the number needed to treat, for example. So, again, read the definition of number needed to treat and how to calculate it. But say, for example, if the number needed to treat is 10,000 people, so that means for every 10,000 people that take drug B, only one of them will see this benefit. Then again, it doesn't make it clinically significant. And also it's about applying it to your actual population. So if I've got a study here with, say, for example, elderly people over the age of 80 or so, in a rural part of Norfolk, for example, then trying to apply the findings of my study, which has been carried out in an urban part of London with like young professionals from 16 to 25, for example, is not of much relevance. I can't then use the same data. So it has to be applicable to the actual population that I'm trying to use and the new data or the research to justify any kind of interventional change on. And then the last few points here, just again, they're more generic things. So they were mainly for the Cambridge lot, so the public health lectures. And I'm sure George's have some as well, which you can refer to, but they're quite useful. Clinical governance, next slide, please. Again, I'll just keep this short because clinical governance, it's one of those things where you just have to learn the definition, and because they might ask you and just regurgitate it. But a big part of that is clinical audit, and they might ask you to take them through an audit cycle. So it's about being aware of how to carry an audit, what makes an audit, and how does that differ to a quality improvement project? How does an audit differ to service evaluation? How does that differ to a research project as well? So with an audit, as you know, you'll have set standards or guidance before that you'll be trying to assess how well you kind of your practice or your current practice is with regards to that, and then assessing how to improve any discrepancies between the standard and what your actual practice is, and then putting in some form of intervention and re-auditing. So it's not about gathering new information, whereas research is all about attaining new information. So it's just about knowing the simple kind of differences. And again, if they ever ask you to define anything like an audit or like research, it's very good to kind of, once you've given your definition, to then go on and talk about an example that you've done. They may kind of shut you up halfway, but it just shows you're keen, and it shows that you just haven't read it out of the book and you've actually gone and walked the walk as well. And then the last slide is just a bit of a conclusion. So basically, this is before interviews. Make sure you get good enough sleep. Like anything, you're going to be nervous on the day, and cramming just doesn't help. And knowing your application well, the clinical scenarios, which we've been through, the rates algorithm, so recognize, assess, treat, and escalate, and just read the Oxford Handbook of Clinical Medicine, the emergency at the back, and then find a small stats book just to go through, because that will be helpful for the day. And yeah, good luck with your application. That's it really from me. If there's any questions or anything that I can help with, then feel free to speak up.
We got one.
I've got one, okay.
Are Whitespace questions talked about during the interview?
Okay, so my London interview, not at all, because there are no Whitespace questions. West Mids, I don't think they actually brushed on it at all. But the issue is, a lot of the time, the interviewers wouldn't have actually read your Whitespace questions. So there'll be different people shortlisting you to those who will be interviewing you, and the interviewers might have 5 minutes of your application. So certainly when you are answering, bring up stuff that you put in your Whitespace questions, and don't feel like you're repeating yourself because you've already mentioned it in the Whitespace questions, because they will score you extra points as they may not have mentioned it. However, the Whitespace questions are relatively generic questions, like why do you want to study here? How would you carry out a research project? Give me an example of leadership, management, or like your teaching experience. It almost seems like a lot of these questions, especially outside of London, are just repeated using different words. And so it doesn't really feel like an expansion of your Whitespace questions. It feels like you're more kind of repeating yourself or just clarifying parts which they may not have understood. Is that okay?
We've got another one. How does choosing a research project work once you're in? Should you have an idea of what you want to do specifically at interview?
So London is very different to other deaneries. With London, you rank all of the, I don't know if you've seen, but London and South East, so many programs you can rank, I think up to 1, 3, 5 or something. And they're all themed. So say, for example, there are just over 10 surgical programs. Most of them are vascular or general. And then there might be like a hematology program at King's, for example. So a lot of the time, depending on how you rank and what you get, you'll just fit into that department. And as soon as you get the post, you can definitely be in contact with them and sort of discuss with them about what you'd like to do. As to going to an interview with an idea of what you want to do, it definitely helps for London, because you may well be asked. I don't know anyone who was, but just knowing your research interests and knowing about basically how you plan to go about it definitely helps more outside of London. So say, for example, if you had an interview at Oxford or Cambridge, then my first piece of advice would be to contact the prof or, the postdoc running the lab or running the type of research that you want to do, so that when you get to interview, you can certainly bring it up and say, I've been in discussion with, I don't know, this lab already, and I know that they have this project going on. I've had a similar idea about this, and this is how I think I can take it forward. That certainly looks more impressive outside of London, contacting the department once you have an interview. Because if you turn up to an interview outside of London without an idea of what project, or you don't need to know the project, you just need to know what you're interested in, or having not made an attempt to contact the prof, then it doesn't look great, because most people will.
Got another one.
Okay.
People that you're working on but haven't yet published on your Whitespace question.
Sure. So Whitespace questions, it very much depends. If it's a project that you're very proud of, and say, for example, you've managed to go from start to finish, you've got ethics approval, you've got IOB approval, you've got been successful at applying for a grant, you've done everything apart from just publish it, then again, yeah, that looks very good in your Whitespace question. But it certainly won't score you extra points if it's just like another similar project or another similar publication that you've done, because there will be sections to list all your publications and that will score you points. So unless it adds to your application, in that you can demonstrate a new skill or like one of your attributes, then I wouldn't repeat myself, because you've scored the points for that in the publication section. So I wouldn't repeat myself. No. Oh, good.
One sec, I'll pause. I'll stop the recording.